does BRCA testing in asymptomatic women reduce breast cancer incidence or improve outcomes? And the type of research that would actually be done is really around outcomes research. And it by virtue of the question, it requires many disciplines. So it's population monitoring of morbidity, mortality, benefits, and risks of studies. Does that help you? Is that a helpful example for you to think about the different stages and the way, even though it's all associated with genetic mutations in terms of breast cancer, you can actually start to see how different research questions, different research methods are undertaken by different groups of teams, and how the work of each team and the new knowledge they generate is then translated to another team who actually start to work on it to translate for different population settings. And you can see how, you know, from little things, big things grow in terms of the way in which we can take that knowledge. And that's really what we're needing to do in terms of translational research. So I think it's helpful probably at the stage you're at to think about translational research as kind of in two camps. So one's actually really quite product driven, and that's what occurs, really what you're doing probably, what occurs from bench to bedside in the development of new drugs, devices and treatment options. And then versus what people like myself and Nicole and potentially Janet are doing, which is very much around community and policy focused translational research, which is actually about translating the evidence into practice. So has anyone got any questions at this point? Is this too much detail?
No. Can I ask a question to all of you guys? I said before that predominantly you were all going to be T1 researchers. Who disagrees with me now? Thank you. Okay, you're T2. That's not fair. Of the T1 researchers, who particularly from the slide that Jane has shown, who sees now that you actually have someone over your career, not now, but over your career, how you can actually potentially follow a path which is T1 through to T4. This is why you're all the future.
We need you. Sorry, are you going to tell me something?
No, I'm done. I'm just wanting to make
I've
a
got
point.
your students on a background too. I don't want to labour this
quiet
point.
people, Jane.
They're quiet. Not like the rowdy nurse. Oh, sorry. I haven't used a mouse for such a long time. I've got my laptop. Sorry, I'll just get back to it. I'm not going to go through these definitions, but happy to make my slides available if you're interested. But just to really think about, there's some good definitions about what we actually need about knowledge translational research, and that probably is a term that really came, probably almost preceded translational research. We now, you know, talk about dissemination and implementation science, and there's a journal devoted to that. So that's actually really about how we actually get that evidence out into practice. You know, this is a framework for thinking about that implementation science. You know, these are the questions that people like myself would actually ask in the clinical setting. You know, what are the outcomes, the gaps we're looking at, what evidence, what is the evidence to support practice change, what are the barriers and enablers to change, you know, what makes it easy for people to change, what makes it hard. They're really quite critical questions to think about in health, because everything has a hook, and everything has, you know, barriers, and there's lots of barriers to change in our healthcare system. And then we have to think about what intervention is most suitable at this time, because there might be a really, really suitable intervention, but sometimes for people like myself, you actually have to be quite pragmatic. And often it's you know, there's two questions I often ask myself, and this comes from a health planning framework called Pre-Seed. And to me, the two questions that are important is it changeable? Is it important? Yes, no. And is it changeable? Because there's lots of health things that are really important, but they may not necessarily be changeable. And that might be because of the policy environment, the political environment, the environment in the healthcare system, the current funding mechanisms, the way in which we pay doctors or the way in which we pay nurses or reimbursements. So there are multiple factors that will actually impact on how we actually get better familiar with the PICO format? If you're from a lab, you may not be. If I was speaking, I spend most of my time speaking to doctors and nurses. But just to give you a rough idea, because I just wanted to say this is what I'm going to present, and this is often how doctors and nurses would present. So we use what we love acronyms, or so we can remember things. So this is PICO, which is really talking to patient population, and then we talk about the intervention, comparisons and outcomes. And what I was going to do was use this format to talk about the cancer challenge that we've been funded to do, which is a translational research, which really, to me, is very much a T3 research. I thought there were pictures there. So what was the problem and the population? So we're looking at cancer pain. How can we make it better? You might be surprised to realise in 2013, probably 75% of people with a diagnosis of cancer will actually report having pain at some stage. Many of our patients will tell us that their pain was at a level that it was so debilitating that it really impacted on the way in which they functioned during the day and the way it impacted on their well-being. So pain is often a symptom of cancer. It's often often the symptom that prompts people to seek treatment. Pain will often resolve as a result of appropriate cancer treatment, but not all pains do. So there's quite a high burden of pain in our population. When you actually have a diagnosis of cancer, your whole world changes for a number of reasons, but one of the major reasons is, apart from it being a potentially life-threatening illness, but really these days it's really many cancers are now a chronic illness, is that you actually have multiple encounters with health providers. You will be seeing your GP. You will actually be coming perhaps to see radiation oncologists. You will be seeing surgeons. You will be seeing community nurses. You will actually be coming in if you're having chemotherapy or some sort of cancer treatment, you'll be seeing a range of cancer care nurses in ambulatory care. You may have occasions where you'll be admitted as an inpatient either because you've got an infection, or because your asthma's playing up, or you've ended up with febrile neutropenia. So you have multiple encounters with healthcare providers, and sometimes if your disease is progressive and is life-limiting, you will be referred to palliative care. So even though you have these multiple encounters, still a lot of people have pain. So cancer pain, unfortunately, is frequently under-recognised and under-treated, and what we know from the evidence is that it's rarely comprehensively assessed, even though that is evidence-based practice guideline. So this study is what we would like to think was a fairly simple and straightforward study. In actual fact, pain is complex and there are many components to it, but it's hard for us to treat pain effectively if we don't really assess it properly in the first place. And that is just one part of this huge picture of why pain is challenging in cancer. So this is an intervention that was really, the target population was focusing on cancer and palliative care clinicians. And we have, based on the information, the data we had, where we identified that they didn't always have the best, knowledge wasn't as comprehensive as it could have been around cancer pain assessment, that they didn't always know what were the components of a comprehensive pain assessment. Despite the fact, having had quite a bit of education, we elected to actually use a spaced education format, which I'll talk to you about in a moment. But we've also, of late, decided to integrate audit and feedback. And I'll speak to those two items. Spaced education was a healthcare provider. The group we're talking about are already in the health. They've finished their education, although we would like to think they're lifelong learners. They're actually out there practicing, seeing patients every day. It's actually really hard if you're a clinician to get time to come out to spend a day getting education. So the beauty about spaced education, or the appeal of spaced education, which was developed at Harvard Medical School, is that clinicians actually just get one or two questions, clinically based questions, based on the evidence, sent to their email address. They click on the link and they actually answer the question. As soon as they answer the question, they get immediate feedback, right, wrong, your answer, it shows a rating, 80% of your colleagues got it right and this was the correct answer. And then it shows if you got it wrong, how many other of your colleagues got it wrong. So it actually also has a benchmarking component, and it's benchmarking you with your peers. It doesn't name your peers, there's no name or shame, it's just very general. But also too, it actually includes some take-home messages. So it says, if, depending on the response that the person gave, what was the take-home message? What would have been the consequences had they implemented that decision in clinical practice? And then it has links to evidence-based practice. This takes a couple of minutes. Is that fair to say? Nicole's really the expert in terms of spaced education, but it only takes a couple of minutes to do. So it means in a very short period of time, even if you're on the board, you could actually answer and have some form of education. You have to actually get the questions correct twice, so they go back into the data bank and then they get re-sent out. When you've answered them correctly twice, they get retired. And the principles that this is based on is around two theories, and it's about the testing effect, so testing your knowledge, but then giving you some knowledge about if you haven't got adequate knowledge, but also about spacing, so that we actually give you not a whole lot of information at any one time, just sort of bite-sized pieces, but then we come back and reinforce the message. So that's one component, and then because we were actually collecting quite a bit of audit data, and we know in terms of changing clinician behaviour that audit has been demonstrated to have some impact. It doesn't, it's not high impact conversion, but it has been shown if you can provide tailored feedback to people that they're more likely to reflect on their clinical practice and may do things differently. So we've decided to include that into this study. So the control, bearing in mind it's cancer clinicians, and bearing in mind this is research, so the type of research I have to do, people have to consent to be involved in, so they're not required to be involved in it. So we estimated that we kind of knew our sample wasn't going to be large enough to do a randomised controlled trial, which we really would have liked to have done. So we knew that that was too small. We thought we might get hopefully about 100 participants, but we need to keep them in over time. So it's a pre-test, post-test design, a quasi-experimental research design. But to try and add some robustness to the study, at one site we're doing what we call a wait-listed control. So people who enrol at one site will actually get randomised either to getting the intervention immediately, participating in spaced education, or they'll actually get to wait until the study's finished and then they'll actually get to do it. And that is one way of getting some randomisation, but we can only do it actually at one site. So what's the outcome we're looking for? We're actually wanting to see a 50% increase in evidence of comprehensive pain assessment for patients with cancer-related pain. So we want to see that if patients come in, for example, to Prince of Wales and tell a clinician or they're noted to have pain, we want to see when they see a cancer nurse and or doctor that we actually see documentation with regards to their pain. And we also want to see an increase in knowledge of doctors and nurses' pain assessment knowledge. So this is just to give you an idea of what the study design looks like. So as I said, it's a pre-test,